So yeah, we're at Welcome and Ames. We're pleased to have Dr. Timothy Agnew, who's a consultant psychiatrist and psychotherapist with the NHS Highland Personality Disorder Service. And he'll talk through a whole range of topics, or as much as he can fit into his 40-minute slot. So that will include definitions, how personality disorder is thought to develop, how mental health services respond, and the overlaps between personality disorder and substance use. And then there's opportunity for Q&A and any open discussion that you want to have. And then following that, we'll have Gordon Hay, who's a senior improvement advisor within the mental health improvement portfolio. He'll give an overview of phase 1 of the personality disorder improvement program, which completed earlier this year, and then briefly outline the next steps for the program, which is in its early phase of development, and how it'll respond to the recommendations that arose from phase 1. And again, hopefully there'll be a little bit of time at the end for any questions for Gordon or any final thoughts from any of our participants today. But it's great to see so many of you here. See, there's 146 and ticking up all the time. So yeah, it's great that you're here, and I'm sure it'll be worth your time, and look forward to hearing what Dr. Timothy Agnew has to say. So I'll hand it over to you, Tim.
Okay, thanks very much. So I was hoping today to talk a bit about personality disorder and substance misuse and the interface between the two. Can everyone see the slides? The title slide?
Yep.
Yep. Okay. So there's quite a lot to get through. I'll try and give an overview, but I'm happy to talk in a wee bit more detail about any aspect of anything we cover, or anything, in fact, that we don't, that you think I might be able to give a view on. So okay, I'll try to talk a wee bit about what's meant by the term personality disorder, specifically with regards to ICD-11, how it's thought to develop, how do mental health services respond, or perhaps how should they respond to personality disorder, a bit about the interface between personality disorder and substance use, which I think is a complex relationship, and then there'll be time for discussion. You'll all be aware that we recently moved from ICD-10 to ICD-11 in terms of how we describe and I suppose define various mental and behavioral disorders, and personality disorder was one of the conditions that underwent most change from ICD-10 to ICD-11. Should say before we start here, I normally kind of say at the start of any kind of talk or discussion around personality disorder, I'm using the term personality disorder with full appreciation of the problems that term itself has, and the controversy around the term itself and even the concept. But it is the term we have. It's a term that we have in ICD-11. I don't like it, but I'm not meaning anything in particular by using the term, other than talking about the set of problems that I'll go on to describe in a moment. So the problems with the terminology is recognised, but it's the least bad way of referring to this problem set, I think, certainly for the purposes of a presentation. I'll talk about the general criteria, a bit about some of the other dimensions that have been thought about and drawn out in ICD-11, which weren't there in ICD-10, and briefly touch on related concepts, which personality difficulty, which sits below mild personality disorder, and complex post-traumatic stress disorder, which looks very like borderline personality disorder plus PTSD. Again, terminology is a perennial issue here. Okay, so personality, first of all, is described in ICD-11, and I think it's a reasonable definition as referring to an individual's characteristic way of behaving, experiencing life, and of perceiving and interpreting themselves, other people, events, and situations. So it's to do with the kind of individual tendency to respond in particular ways across time and across situations. Just to kind of very, very briefly remind people about ICD-10, and there are also some DSM specific personality disorder subtypes in here, but ICD-10 and DSM still does thinks about personality in terms of categories and types, and that doesn't really reflect you know, I suppose the evidence that we have and the work that's been done and the literature that's been developed around personality and personality disorder. But there was, I suppose, some clinical usefulness in some of these terms, and borderline personality disorder in particular has been there have been treatments which have been shown to be effective for this condition, and that's been carried across. Now, this is meant in a light-hearted way, but I think there's some kind of important information being put across in this diagram. But all of these, with the exception of borderline, are no longer included within ICD-11. So there's been a move from this categorical or type-based description of personality disorder towards a more dimensional approach. So I'll talk about what the dimensional approach means in just a moment, but as with any mental disorder, whether it's categorical or dimensional, any description requires a kind of set of criteria, and of course that's how we make diagnoses within mental health. This is a kind of paraphrasing of the general criteria for personality disorder, which must be met for the condition to be or for the diagnosis to be given before you do anything else in terms of thinking about severity or a finer grained description. Are the general criteria met? And of course, whatever we do, there will always be some kind of clinical judgment involved in this. But we try and increase the reliability with these criteria so that different people are thinking about as far as possible the same point for the threshold for the diagnosis across different situations. So personality disorder is a marked disturbance in personality functioning, which is nearly always associated with considerable personal social disruption, and the central problems are to do with disturbance of aspects of the self or functioning of aspects of the self, and problems in interpersonal functioning. And those difficulties are shown through problems of patterns of thinking, emotional experiencing and expression, and behavior. So those are the general criteria paraphrased. So there's something about pervasiveness, which is problems related to personality across different situations. Persistence, which is problems lasting over time, a considerable period of time, and that the problems are causing distress or dysfunction or both. So the general criteria must be met, and then one of the differences between ICD-11 and ICD-10 is this idea of severity. So mild, moderate, or severe would be the next step, and essentially that's to do with how pervasive the problems are. So mild would be kind of some areas of life affected. Severe would be most or all, and the kind of level of disturbance would be less at the mild end in terms of those cognitive, emotional, behavioral, and interpersonal and self-concept problems, whereas they'd be much more severe at the severe end, and the distress and dysfunction would also be more severe at the severe end. So that's kind of roughly what the descriptions are in parsing out mild, moderate, and severe. A complete change for ICD-11, and I think it's very useful clinically, actually, is this idea of trait domain specifiers. So we've got 5 trait domain specifiers which map more or less to some of the big 5 personality trait domains, which you may have heard about. So negative affectivity is the first, and that's the tendency to experience a broad range of negative emotions. So that's fear and shame and guilt, sadness, all of these kinds of things. And that maps to neuroticism, which is one of the big 5 trait domains. Again, most people have, well, all people, I would imagine, experience negative emotions at some point in their life, or perhaps even relatively frequency and to an intense degree, but that clearly doesn't mean personality disorder is present. These things must be causing problems in terms of impairment of functioning or significant distress to be there as part of a personality disorder diagnosis. So detachment is the tendency to maintain social and emotional distance. Dissociality is about lack of empathy and self-centeredness. Disinhibition is about impulsivity, recklessness, and those kinds of things. And incapacity is about rigidity and perfectionism. And those are the 5 trait domain specifiers. Now, you'll see there right at the bottom is borderline pattern, which is carried over really from ICD-10. It's not a trait domain specifier. And what you would do is describe things in terms of those trait domains with borderline pattern as an additional specifier. So almost everybody with a borderline pattern would have negative affectivity and disinhibition present. Many would also have dissociality present as part of that pattern, and of course other problems with different trait domains may be present also. But borderline pattern's an additional thing, and the reason why it wasn't dropped was because that would be, I suppose, in some sense throwing the baby out with the bathwater, because that's where the evidence is for effective treatments in personality disorder. There are effective treatments for borderline personality disorder. It is a common clinical presentation. It's a syndrome that most people working in mental health, and maybe even health, will be familiar with. And it's something that causes high levels of distress for people who experience it and those who live with them, or love them or know them. So that's why that was kept. And of course there'll be it might be worth thinking about the folk that you work with, and thinking about how their own personality might be in terms of these trait domains, and maybe even perhaps the borderline specifier. And I'm sure you can recognize some of these trait domains present in some of the patients that you work with. Okay, these are the general criteria in a bit more detail. The only extra points I'd say is that one of the changes from ICD-10 to 11 is that ICD-10 talked about the problems needing to be there from early adulthood. ICD-11 talks about a 2-year period. It's much more clinically useful, I think, and it allows people to get on the right treatment pathway more often, I think. Interesting one here, given the topic we're talking about today, is that the symptoms, personality disorder, are not due to the direct effects of medication or substance, including withdrawal, and not better accounted for by another mental disorder or a physical health condition. So that's quite interesting to note. My own view is that when you get to the point very often of someone having significant and complex problems and presenting to services that have been about for a long time and maybe involve substances and maybe involve personality, it can be quite hard to kind of disentangle what's what, and apart from kind of physiological dependence, maybe almost academic, and it's about looking at the person as a whole and all of the problems they present with and prioritizing those problems. Okay, the other final thing for those of you who may be working with adolescents is that personality disorder, previously it was kind of cautioned against making the diagnosis in adolescents and those under 18. That's no longer the case. The diagnosis can be made in any young person who's past kind of puberty. Basically, it's not recommended to be making that diagnosis in childhood, and I think that's kind of understandable. But for adolescents and afterwards, the diagnosis can be made. But this is an important point: not if the problems are developmentally appropriate. So a lot of adolescents will have problems related to self-concept and relationships and impulse control and all of these kinds of things, and emotion regulation. More problems in adolescence than in adulthood. And if you follow the natural history of most individuals' development, that will be the case. However, there needs to be something developmentally inappropriate for the diagnosis to be made, so that it needs to be outlined well beyond what would be typically expected of an adolescent for you to even start considering the diagnosis. Okay, so this is really a kind of summary of what it means, what personality disorder actually means in real terms, and I'm aware that sometimes it's used as a kind of vague term that has in the past been used to block people from services, and there have been papers actually even written with titles such as patients with the title was something that and I'm paraphrasing slightly, personality disorder the patients psychiatrists don't like, and papers like that. So it's important, I think, that if we're using this term, we're using it in a very specific way according to the descriptions in ICD-11. Okay, so I talked a bit about self-concept disturbance. What does that mean? That's talking about things like identity, and kind of identity disturbance can be particularly pronounced in folk with a borderline pattern, for example. Ideas of self-worth and self-esteem and those kinds of things. This idea of self-appraisal, which is how accurately are you viewing your own strengths and limitations when you compare that to how other people are viewing the same characteristics in you. The capacity for self-direction, this is about planning, this is about problem solving, this is about goal setting and meeting those goals, short-term and longer-term goals. Interpersonal dysfunction. This is about interest in relationships, how well you can think about what might be in another person's mind and their perspective. It's about the overall capacity and ability to make and keep effective reciprocal relationships, and how conflict is managed in relationships. So you'll see in here, in terms of self-concept, in here in terms of relationships, I'm sure you'll see in a lot of the patients or clients or folk you work with, it'd be interesting to reflect if any of these areas are problematic in any way for those people or those people around them. Similarly, you'll see a kind of overlap, I think, between some of the things that are talked about in terms of emotional, cognitive, and behavioural manifestations, and some of the problems that present in the folk that you work with. So it kind of, in terms of emotional manifestation, range and appropriateness of experience and expression, I think is really can be over-controlled or under-controlled. And this idea is borne out in terms of emotional over or under reactivity. The ability to recognize, acknowledge, and I would also say tolerate emotions that are difficult or unwanted, and very often this can be a big driver for people in terms of, I suppose, unhelpful emotion regulation strategies such as self-injury or substance use or eating regulation in one way or another. Cognitive manifestations, this is about how people view themselves, view interactions with others, especially under stress, how decisions are made, and how belief systems are for that person, how stable they are they able to change, are goals able to change if one goal is not able to be met, is there flexibility within the person to be able to shift and change either their strategies or their interpretation of the situation or the goals that they have. Behavioral manifestations include things like flexibility in controlling impulses and modifying behavior based on the situation, consideration of the consequences. So that's to do with kind of how much of a person's behavior is immediately driven by internal and external cues, how much is able to be how much behavior is able to be modulated in the service of longer term goals rather than short term goals, and these kinds of things. How much behavioral control remains in situations of intense emotion, stressful circumstances, and are there risks of harm to self or others that relate to the behavioral manifestations of personality dysfunction. So some of the areas that the stress and dysfunctional impairment will kind of arise are things like personal domain, the family domain, the social domain, educational domain, occupational domain, or any other important area of functioning. I've talked a wee bit about this, the severity dimension. Essentially, it's to do with mild has kind of less intense problems in less areas of life, going up to severe, which is most or all at a very intense level. But there are descriptions of how those mild, moderate, and severe category, well, not categories, descriptors should be applied. Talked a wee bit about this as well, the trait domain specifiers and what they mean, and also the borderline pattern, which isn't a trait specifier because wrapped up in the borderline description are psychiatric symptoms and behavioral descriptions and so on, as well as kind of more trait-based features. Okay, so I've talked a bit about negative affectivity. I'll just recap on it because it's important. So that's the tendency to experience negative emotions. And you can see some common manifestations there, include both emotional experiencing, emotional expression, and the impact on relationships. Detachment's about social and emotional detachment. Dissociality is about self-centeredness and lack of empathy. Disinhibition's about impulsivity, lack of planning, rashness, irresponsibility, distractibility, these kinds of things. Anacostia is about perfectionism and rigidity. And the kind of borderline pattern is essentially the same thing as DSM, borderline personality disorder. So it's got 9 criteria, which I'll not go through now, but anyone who's familiar with the condition will know that there are kind of general criteria which were covered, and then for borderline personality disorder, as was, or emotionally unstable personality disorder, borderline subtype in ICD. In DSM, there were 9 criteria, and the ICD-10 version was pretty similar. So what we have now is basically a just wholesale move of this across into ICD-11. I'll talk a wee bit about complex PTSD, just very briefly. Lots of the folk that you see will have experienced significant adversity and trauma in their lives, and complex post-traumatic stress disorder, or complex PTSD, or complex trauma. These kinds of terms were bandied about, I think, in a fairly vague way for a long time, and rather unhelpfully. ICD-11 has kind of defined for the first time in a major diagnostic manual complex post-traumatic stress disorder. It's not in DSM, and people that were using the term were using all sorts of different kind of definitions for it. It's now pretty clear what it means. It means that you've got essentially 2 triads, or 2 clusters of problems. First triad is PTSD, classical PTSD, which is avoidance, hyper-arousal or threat, hyper-awareness, and so avoidance, hyper-arousal, and re-experiencing. And the second triad is disturbance of self-concept, disturbance of relationships, and disturbance of emotion regulation. Now, to have complex PTSD, you must have classical PTSD. If you don't have PTSD, you can't have complex PTSD. And if you go on to look at the second triad that I talked about there, self-concept disturbance, relationship disturbance, and emotional regulation disturbance, there's a massive overlap there with personality disturbance. Now, there will be times when complex PTSD is the most appropriate diagnosis to make. But I think if the problems have been about for 2 years or more, and especially if there are problems with impulse discontrol and self-injury, then probably you need to be given consideration to the diagnosis of personality disorder with borderline pattern and co-occurring complex PTSD, and that allows certain treatment pathways to be explored. I should say that while there are treatments available for PTSD, evidence-based treatments, there's no robust evidence yet, because it's such a new diagnosis perhaps, is part of it, for complex PTSD, although there are treatments and emerging evidence for borderline personality disorder plus PTSD. So it's kind of, I suppose, something to think about. Our practice within our service would be to, if both things are there, we'd make both diagnoses. So personality disorder with borderline pattern and complex PTSD as well, if that's present. And about 50% plus of the people we see will meet criteria for PTSD. So 50% of people with borderline pattern will meet criteria for PTSD, and at least 75% will have been exposed to a major traumatic event that they can recall. Should also note, when we're talking about traumatic experiences, that the most impactful period in life are the first 2 years of a child's life, and very rarely are there clear memories from that time. But we still know that if bad things happen to very young children in that period, then the risk of all sorts of negative outcomes is very much higher. Okay, so I've talked a bit about that. That's just a summary of PTSD and the extra triad. I think it's a really helpful addition, this, because for the first time, there's clarity around what's being talked about when people are talking about complex PTSD. Okay, so I've kind of touched a wee bit on some of the things that might be involved in the development of personality disorder. In fact, like most conditions that we see, there's a kind of constitutional bit, a heritable bit, and a environmental bit. And actually, the kind of spread of this is roughly the same as condition like schizophrenia, for example. So you're probably looking at temperamental factors, heritable factors being about 40%, temperament being the kind of inherited bit of personality that you see in very young babies before their personality is fully developed. Environmental factors probably make up about 60%, but interestingly, if we look at personality overall, about 40% is thought to be heritable of contributing factors. If we look at individual trait-based measures, so people filling out their own appraisal of their own personality traits. But when we look at multi-source trait-based measures, so that's people filling out the forms, the trait forms, and someone who knows them well also filling it out, that probably rises to about 60%. So it might that there might even be more of a heritable component than that 40%. In any case, there are transactional processes between these two sets of factors throughout life, actually, but most importantly and most impactfully in early life. And this is probably a good way to think about things. You'll see at the bottom genetic factors, but also epigenetic and other constitutional factors interact with early life experiences and can lead to what we call chronic toxic stress, which is a state of non-resolving arousal, really. So cortisol, adrenaline are high for much longer than they were designed to be high for, because the threat is not resolving. That affects the developing neurobiology and leads to social, cognitive, emotional impairment, which functions as a risk factor for mental disorder, health harming behaviors such as substance misuse, and social problems of various kinds. I would place personality disorder as an exaggerated or extreme expression of social, cognitive, and emotional impairment there. So it's functioning as a risk factor to mental disorder, mental illness like depressive disorder or whatever else, health harming behaviors, and social problems like unemployment, incarceration, and those kinds of things. And so it's just a useful way, I think, of hanging it all together. Okay, so what do we do about this set of complex problems that have such an impact on people? I think importantly, whatever you do, it's useful to think about certain general principles. It's also worth thinking about the overall structure and sequencing of care and treatment, because so many problems can be presented with. It can be hard to know where to start. Some kind of structure and way of understanding how problems are best tackled and in what sequence is very useful. I'll talk a wee bit about specific interventions. The general principles that we would work to within the kind of NHS Highland in our integrated pathway are collaboration, consistency, validation, motivation, and self-management. And these are kind of largely drawn from the work of someone, Canadian psychologist and psychiatrist, unusually double trained. It's drawn from his work, and I think it's a useful framework. There, you could parse things into different principles, and there are other sets of principles that are I'm sure equally valid. This just happens to be the way we think about things, and there will be overlap between these principles. So you'll notice here as well that many of the principles I'm talking about will equally apply to the folk you're working with, and I think much more broadly than that. Actually, these principles are useful principles in approaching any work, I think, within mental health and beyond, probably. So collaboration is about the idea that you can't do anything to or for someone. It needs to be done with them, and that needs to be agreed with the person and the worker for any meaningful work to take place, really. Consistency, I suppose, in a nutshell, and we don't have that much time here, but consistency in a nutshell is setting out a clear treatment frame, being transparent and honest with the person, a formal treatment agreement if necessary, saying what is going to happen and what you're going to do, what they can expect from you and what you expect from them. So say what you're going to do, and then do what you've said you're going to do every time. I think that there can be sometimes a temptation to stretch limits or not do what you've said in an attempt maybe to keep someone engaged. I think that always requires a bit of thought, actually, as to whether the stretching the limits is in the interests of therapy or not in the interests of therapy. And there may be times where it is, and there may be times where it is not. But there can be really problematic effects from even bending limits to try and keep someone engaged, because very often there have been relationships that this person's been in before, especially relationships with perhaps a perceived power imbalance, where people have said they're going to do one thing and done something else, and that sticking to and observing limits can actually have a containing effect overall, and sometimes bending rules and stretching limits can have a kind of dysregulating effect for folk who maybe have had those kinds of experiences. Validation. This is about acknowledging the legitimacy, really, of people's experience. It's not about kind of approval necessarily, but it's about acknowledgement and acceptance that that's how things are, and that that people are, I suppose, doing the best they can with the strategies that they have to manage the situation they find themselves in, and putting all that in the context of what's happened to them in their lives. Motivation, I suppose this will be something that you're all familiar with. There's no point, I think, looking at kind of skills work or phase 2 work or phase 3, which I'll touch on in a moment, if the person is not motivated to do the work. And kind of classical motivational interviewing strategies we would use, sort of helping people think about alternatives, pros and cons, amplifying discontent, all of these kinds of things, I think are all really useful. And we would also think specifically about cycle of change type model, I suppose, as a heuristic for thinking about where someone might be in terms of as pre-contemplation, contemplation, preparation, etc. I think that's a really useful way of thinking about change of any behavior, and making that quite explicit. Self-management is last, but certainly not least. This is the key one. This is the major one that all of the others kind of feed into. And this is about kind of personal responsibility. This is about recognizing that the person may not have caused their problems, but they're the only one who can sort them out. And that the job of those working with them is not to sort them out, sort their problems out. It's to help skill those people up so that they can manage their own life and health effectively. And that needs to be made absolutely explicit. So that's something about the general principles, and that applies to any contact, whether that's crisis services or whether that's specialist personality disorder services or general services or primary care or whatever else. That will be a useful framework. When we're looking at a kind of set of problems and how to sequence, we think about a phase-based approach. So phase one is focused on the present, and you'll probably be aware of this. It's also used in other trauma-related conditions as a framework, and elsewhere in mental health. Phase one is about the present. It's about safety and stabilization. It's about stopping behaviors or reducing behaviors that are going to kill the person, or significantly harm them, or prevent recovery. Phase two is about exploring long-standing patterns of thinking and behavior, and often involves specific trauma processing work. You can't really touch that until the phase one work's been done. Phase three is about moving on, connection or reconnection, and within the service I work within, the personality disorder service I work within, we make it explicit that it's work towards moving away from services and installing the, resources in that person's life that are giving that person or meeting the needs that mental health services or other services may have been helping the person to meet. So that's about roles, relationships, responsibilities, education, work-related activity, all of those kinds of things. So some specific approaches we use for those different phases are, in Highland at least, we use the decider, we use steps, we use a supported self-management service, and dialectical behaviour therapy. DBT is used for the most severe patients with borderline problems. Steps for less severe. Decider is used in the CMHTs and in other settings, and supporting self-management is similar. Standard kind of trauma-focused interventions are used, and we have a day service for phase three, work for folk who need it. That's a decider, which is basically the same skills packaged up in steps and DBT as well. All of them are essentially those are resilience building skills. I'll not go into it too much because I'm conscious of time. But essentially, work has been done which has been shown that certain factors confer some resilience to the development of health harming behaviors, social problems, mental health problems, even in the context of adversity and traumatic experiences. And these are the things that have been shown to be most important. Emotion regulation skills, problem solving skills, sense of self-agency. So that's the idea that you control or you have some effect in the world rather than the world just happens to you. Hopefulness and effective interpersonal interactions and relationships, and the skills that go along with that. And essentially all of the phase one interventions I've talked about are aimed at improving and enhancing. Certainly the emotion regulation, problem solving and effective interpersonal skills and self-agency and hopefulness emerge from competent behavior over time. So finally, personality disorder and substance misuse. Reliable data is quite difficult for a number of reasons. One of those is the gross underdiagnosis of personality disorder. So what we know is 10% of the general population, and this is a kind of sampling and structured interview approach, 10% of the general population probably meet the general criteria for personality disorder. If you look at a primary care clinic, you're probably looking at 20 to 30%. Psychiatric outpatient clinic, 40 to 50%. Psychiatric inpatient care, 50 to 60%. Prisons, 80+%. And I don't know of any figures for substance use services, but I'd imagine they're at least comparable with more, I suppose, more general adult psychiatric services. So probably something in the region of at least 40 to 60%, I would imagine. But again, reliable data is limited. We also know there's very high rates of substance use and substance dependence in patients with personality disorder. In addition, we know people with personality disorder are more likely to experience adverse effects, more likely to experience dependence and withdrawal problems, even discontinuation effects from psychiatric medications. So substance misuse and personality disorder can exist in a vicious symbiosis. Now, if you think back to some of the problems of personality disorder, there are multiple reasons there. I'm sure you can see why people might be using substances in terms of emotion regulation, in terms of kind of trying to manage negative emotions related to impulsivity and a limited ability to weigh up consequences. I'll leave you to think about that further. And just very finally then, how we would approach things is that if there's an active physiological dependence, we would ask for that to be addressed first. If there's harmful use, I think that's probably our standard rather than the exception. We're happy to work with that. What we require is that the person's at a place where they can turn up for therapy, and that we can target some of these things within the therapy. What we find with people with active physiological dependence a lot of the time, and certainly with more chaotic use, is that they don't turn up. The attachment that would normally be developed with a therapist is much harder to get to, and therefore that's much harder to use as a kind of a mechanism of change in the therapy. And emotional learning is very difficult. So there are a number of factors there why we would put that really at the top of the list. We don't require people to be abstinent, but we require them to be able to turn up and emotionally process things. Okay. We often see substances as a secondary controlling variable in key factor in many other unhelpful behaviors, and it's often an early focus of treatment. And we would aim to reduce people's substance use very early on in treatment, and get that as a commitment during pre-treatment, certainly in DBT, for example. And that would include psychiatric drugs. Very often antipsychotics and antidepressants and things like that are used in a way that I don't think is necessarily very helpful, and can actually impede evidence-based treatments for this condition. That's all I wanted to say in overview. I'm quite happy to take things to discussion now.